We're featuring a world-renowned expert in radiation oncology. It is my great privilege to introduce Professor Jürgen Depes. Professor Depes joined us from Heidelberg University in Germany, where he is a globally recognized leader in the field of radiation oncology. He has made immense contribution to our specialty, particularly through his pioneering work and extensive clinical expertise in particle and proton therapy. He will be presenting on a highly relevant and fascinating topic, proton therapy, a clinical necessity or a luxury. Before we begin, just a quick reminder to our audience to please leave your questions in the question and answer sections, and we will address them after the presentation. Professor Davis, it is an honor to have you with us today. The virtual floor is all yours. You can begin your presentation.
Yes, thank you so much, Dr. Alleheim, for the kind introduction and also the very nice words. It's a great privilege and also honor to be able to present to you today the data on our experience regarding proton therapy and the way ahead which we see in that area. Currently, our department is equipped with all latest technology, photon treatment, but also the particle therapy is an integral part of our treatment options, which we currently use. And we just have one single room solution from IBA under construction because it will broaden our options in treating our patients. The rationale for using particle therapy is already very old. We have this stopping beam, which generates the so-called Bragg peak. So the beam is stopping at the level of the tumor and behind the tumor and in front of the tumor, there's significant less beam. And this leads to a dosimetric advantage, which has been acknowledged many, many years ago. And therefore, also over the years, many particle centers have been established and are under operation. As you see here, there's worldwide interest in using the particle therapy. So if you ask experts on the advantage of the particles who might benefit from proton therapy instead of X-rays, there is a broad consensus that about 30 to 50% of all patients will have a benefit nowadays from the proton technology. And this holds especially true for reducing toxicity, but also for dose escalation. When we did this expert review, there's obviously some difference depending on the experience. If you ask the oncology people, they are less, they report lower numbers. If you have experts working in the field, they definitely report higher numbers of patients who benefit from that. And especially if you ask patients or doctors who are involved in the treatment of pediatric cancer, you see there's even one person who mentioned that nearly all patients will benefit from the proton therapy approach. This has led to the increasing numbers. We started here back in '97, and at the time when the PDCOG meeting, this particle therapy cooperative group meeting, consisted of, at that time it was 80 people when we had this meeting here in Heidelberg. When we had the later meeting in 2009, and when we had already 600 people, and nowadays, as you know, there are more than 3,000 to 4,000 people going to a PDCOG meeting. And according to that, also this capacity is still growing because there's a growing need. There are different approaches to attribute proton therapy to different patients. There is the report from the Netherlands. They did an analysis, what are standard indication, meaning where do we have already established evidence, where do we have potential indications, for example, the liver tumors. And then they also used an approach using model-based indications, meaning based on a virtual treatment planning. They identified patients where in comparison with the photon world, and I'll go over to that later on, the protons have a significant reduction of side effects. And obviously, there's this large group also where our aim is to reduce the secondary tumors, such as children and young adults. Regarding the comparative treatment planning, they used this model-based approach, especially with the aspect, how can we select the patients for the proton therapy adequately, and using the side effect model. What's very important here, for example, if you look into swallowing dysfunction in the patient, for example, especially modulate with the dose to the upper constrictor muscle, you see, for example, here in a typical situation, if you have with proton therapy a lower dose, it depends very critically if you treat a patient over here. For example, if you have already a very high rate of toxicity, such as in xerostomia, you only have a limited advantage, even if you significantly lower the dose. And therefore, it's important, for example, if you look in a situation like that, where the same reduction of dose leads to significant reduction of normal tissue effects. This is how they selected the patient in order to predict it. And fortunately, Hans Langendijk has now also shown that his prospectively collected data support this hypothesis that you can predict patients who have an additional benefit or a larger benefit compared to a lower benefit. We used our facility to deliver protons, and in Germany, the indications for protons have the same structure. We have a wide variety in children and young adults. And within phase 2 trials, we can treat all the other patients in order to shed light on the questions, what is the advantage? So our healthcare insurers pays for the treatment of proton therapy, but they said, okay, we want to have, in the end, we want to have the data in order to be able to tell on the long-term run what is the absolute quantitation, what is the absolute advantage of this kind of technology. One of these typical examples are the consolidation treatment, for example, for mediastinal lymphoma. This is a comparison between IMRT and IPT, and for example, especially in female patients, you know that there's a problem. You either deliver dose to the breast or dose to the spinal cord. And with proton therapy, you completely avoid the critical structure, you avoid breast, you avoid, but also, for example, here, the esophagus, and you have a significant lower risk of esophagitis in this group of patients, but also the long-term side effects, such as the risk of induction of secondary malignancy, is significantly lower. This risk of secondary malignancy in malignant lymphoma can be highly reduced, especially, for example, in young adults, or for example, here, the risk of esophageal cancer can also be reduced. This is one of the reasons why the indication for protons in many children and young adults is one of the main working horse in the treatment. There's even a situation nowadays which is not often that strongly acknowledged. These were data coming from original treatments which you did at GSI and have been later also confirmed by the Boston group and the MD Anderson group. This is the aspect that we see a growing number of patients which experienced cancer during pregnancy. At least in Germany, we have an epidemiological development that the mothers get older and older, and because with the aging population of the pregnant patient, also the risk, for example, of breast cancer and other cancers is increasing. The interesting aspect is if you treat these patients, for example, with proton therapy, there is a significant reduction, for example, here in comparison with the photon to pencil beam scanning. With pencil beam scanning, you don't have a significant dose and you can safely deliver, for example, a mediastinal treatment or a treatment in the area of the breast or also of the brain without any significant dose to the fetus. Whereas if you do the same with the photons, you get into a critical area with a dose to the fetus, which comes in the order of 40 to 100 millisievert, which is typically why we avoid that. And we do it now within a clinical study. And for example, after proton therapy, you see here the dose per fraction it's 52 microsievert per fraction. So it's really literally a very low dose. This is, for example, like a flight, a transatlantic flight. You experience a dose of 80 microsievert per flight, and therefore we can be considered to be very safe. In pediatric oncology, it's the same. It's all about avoiding dose to normal structure. We have these very established indications for the proton therapy. And for a long period of time, proton therapy was considered to be this method of care for small tumors where we need a precise treatment. We nowadays have learned that especially the use of large field treatment, you see the largest absolute difference. In small treatments, you have a relative difference, but in large treatments, for example, like craniospinal irradiation, you see, for example, here in this comparison, this is a comparison from Turkey. 25 Turkish centers, one Proton center, have compared their different technologies in treating craniospinal treatments. And for example, with the Proton, you see that you completely avoid dose to the thyroid, to the heart, to the liver, to the gastrointestinal structures. Whereas with photons, with any kind of technology, if you have just one field, you avoid also dose here to the structures, but you have in your path a high dose, for example, to the esophagus, leading to swallowing dysfunction. And therefore, protons can be considered a standard of care, especially if you use that for the dose to the normal tissue, which is receiving a dose of more than 10 degree. The interesting point is also, if you do an MRI later on, in all the children which have an expected additional growth of less than 10 centimeters. So we asked what is the height of the parent, so the father and the mother. When we take the median, and depending on the gender of the child, we adapt that. And if it's lower than 10 centimeters, we only treat the spinal fluid. Whereas, for example, in a smaller children where we extra higher group, we treat the whole vertebral body. This is currently ongoing study, which is asking, can we really dare to treat only part of the vertebral body? But if you treat only part of the vertebral body, you see precisely that the concept of the stopping beam is really working. For example, you see here, you see here that there's a bony defect here in the spine, and consequently, which has not been compensated. And you see here a longer range, and you see here automatically here that the bone marrow has a fatty structure. And we know, meanwhile, that the limit is exactly 8 gray. So the bone marrow which receives more than 8 gray gets a fatty degeneration, like shown here on this T1 weighted MRI, whereas the other bone marrow stays normal and has also full capacity for basically for the blood volume. Another interesting aspect is this was a 20-year-old, 12-year-old female with the diagnosis of ependymoma. We've seen recently that a deep molecular diagnosis sometimes leads to completely different pattern and also to completely different diagnosis. For example, this by light microscopy, this patient was diagnosed as ependymoma. The new diagnosis with molecular methylation pattern turned out it was a medulloblastoma grade 4, and she received craniospinal irradiation. And this is a patient, nowadays she's 20, 8 years after, and she's a completely normally developed young woman, and meanwhile, she also got a child. When the next question is, if we treat the whole craniospinal axis with protons, are protons different regarding the effect on the normal tissue compared to photons? And this nice study has shown that if you treat the whole brain, there's even a superior intellectual outcome after proton compared to photon in pediatric medulloblastoma, despite the fact that you treat the whole medulloblastoma. And this is a study which is currently under discussion, and also we try to understand that, because there's currently also a strong evidence that you spare for example, if you spare normal structures, if you spare the blood, if you spare the bone marrow, there's a faster regeneration also of our tissues. This is one of the reasons why you see it in your cost-effective calculation in childhood medulloblastoma. Proton radiotherapy, if you don't look just for the cost of the treatment, but the overall cost of care, you will realize that protons are less costly than conventional radiation therapy. And one of the main aspects is, if you compare that, that it's the aspect of quality of life, but also, for example, you have less hospital admissions with protons, you have less necessity for artificial nutrition and feeding tubes and whatsoever in this group of children, which leads to a significant reduction of the costs. Which was the first time that we've shown that protons are cheaper than photons, comparing the overall treatment care rather than just looking for treatment costs. The other aspects of treatment of low-grade glioma is that there's still a lot of discussion if you compare the different approaches with conformal radiation therapy, with protons, and with IMPT. You obviously see that you can spare structures like the normal brain completely from irradiation, which you also see here in this dose volume histograms, reduction of the dose to the hippocampus, to the brainstem. But there has been recently acknowledged that, for example, we see that there's here the radiation-induced contrast enhancement, typically seen in the periventricular area, and typically also seen in areas where the beam is stopping. So probably we have to take into account biological effectiveness right at the end of the stopping beam might be higher and might lead, especially in the subventricular zone, to contrast enhancement. Meanwhile, we can model that very nicely, and we are currently doing this Indigo trial, where we have the control arm, which receives the conventional way, and we have a model-aided optimization way that take into account the biological effectiveness of the proton beams, and are able currently, the first results show that we can avoid this contrast enhancement. Another aspect which has been recently shown and acknowledged, you may ask you, what is the role of protons in a situation like glioblastoma, where we have a diffusely infiltrating tumor, where even the borders of the target volumes are sometimes unclear? And with the comparison between protons and photons, you see that with the protons, we avoid structures as the normal brain, here at the brainstem, in comparison to the photons. But interestingly, you also avoid, let's say, grade 3 toxicity, and the main part of this grade 3 toxicity is hematological toxicity. So by this technology, we treat significantly less blood, which is circulating through the volume compared to the IMRT techniques. And as you know, our brain has a luxury perfusion, so typically about 1.5 liters of blood are flowing through our brain. And if you treat large volumes of the brain, let's say over a longer period of time, you treat a significant part of the blood values. And therefore, we're currently doing a randomized trial comparing in the protons, the photon treatment with the proton treatment, which you see here with the primary endpoint, cumulative toxicity. Why is that so interesting to us? Because, for example, especially if you combine in patients with glioblastoma, the radiation treatment with temozolomide or temodar, you have a significant hematological side effects, and probably the combination of radiation therapy with chemotherapy will be done safely with protons, whereas, for example, you see a higher rate of toxicity in the photons. This is what's currently ongoing, and this trial has now recruited very nicely. The other aspect, as soon as we acknowledge the blood as a critical structure which can be spared, also the lymph nodes are a critical structure, and we have now also growing evidence with protons you can do what we call immunosparing radiation therapy. So we avoid immune system with our proton therapy, which gives an interesting approach to combine proton therapy with, for example, checkpoint inhibitors. This has been shown by Marco Durante very nicely in his lecture, showing that proton therapy are a very interesting candidate if you combine protons with checkpoint inhibitors, because you spare the normal structures of the lymphopoietic system, and therefore you avoid lymphopenia. Now let me come to some randomized trials. Dr. Alterhain is probably very familiar with that trial, which has been done at the MD Anderson Cancer Center with Dr. Frank. And they did a randomized trial from the US and one randomized trial from the UK. And this is a very interesting situation because they nearly have been published very close to each other, one in Lancet in January, one in Lancet in March of this year, with a different interpretation. US interpretation is IMPT is the new standard of care option for patients with oropharynx cancer, whereas in the UK, it's not used routinely because IMRT remains the standard of care. So a little bit different location. I want a little bit shed light onto this question. First, the methodology was a little bit different in both trials. One has 440 patients which have been treated in 21 sites with IMPT. They delivered the same dose, 70 gray in 33 fractions. Also here 70 gray in 33 fractions, however, only in 2 centers, in the Christie's and University College London. So the patients from the UK had to travel large distances to get IMPT. Then there was a different endpoint, overall survival at 2 years compared to progression-free survival at 3 years. And this was a non-inferiority design with a 9% margin. And whereas here they had also a different approach regarding the treatment. Whereas in the UK, the study did not adapt the bilateral neck treatment to the neck node involvement. So all the patients received bilateral neck treatment, whereas here in the US study, there was a similar inclusion criteria, but the patient have been treated with more involved neck node sites. So this was much more restrictive. And as I mentioned earlier, for example, in the trial from the Netherlands with the model-based approach, you would accept if you treat here a larger volume where you have bilateral neck, it's more, let's say, more difficult to see differences in toxicity. What makes the trial so different? They all looked at the toxicity, the feeding toes, tube dependence were less with IMRT. So we've seen in both trials consistently 30% reduction of feeding tube on the long-term run. And there was a reduced toxicity with IMPT, especially in the US trial, especially dysphagia, xerostomia, and lymphopenia. Whereas in the UK trial, there was a difference or there was also difference in with IMRT regarding grade 3 related toxicity. So again, if you look here, for example, for the feeding tube, highly significant feeding tube reduction, especially with the IMPT compared to IMRT, whereas there was also feeding tube reduction in the UK trial, but not for the gastrostomy tube at 1 year, which has to do something also with the care which has been taken from a distant site. The most striking results are the reports on the overall survival in this group of patients. For example, after 5 years, you see in the US trial a 10% absolute difference in the overall survival in this group of patients, whereas after 2 years, you don't see any difference. And there's only, they report only 2-year results. And as you see here also, this is also very typical for head and neck cancer patients, because we nowadays do a lot of re-irradiation, retreatments, and also salvage treatments based on different parameters, even like, for example, using in a recurrent situation chemotherapy or checkpoint inhibitors. you see the effect on the overall survival only after 3 years. But what's also very important here, obviously, these curves, they get the different disease curve gets larger over time. This is very typical for head and neck cancer, and very typical for also another group. I just like our own data on the adenoid cystic carcinoma, for example. Also, where you see there's nearly no difference after 1.5 or 2 years, but then the curves are spreading against each other. You see over time this difference gets larger and larger, and therefore it's important, if you want to draw conclusions, you have to look at long-term results. This is one of the trials we are currently performing in prostate cancer, and there's a lot of discussion on that. In this trial, we currently have a multicentric randomized phase 3 study where we compare in a salvage situation protons with 21 fraction, with 9 fractions times 3 gray, with the same fractionations with photons, and the conventional fractionation with photons. The primary endpoint is improved overall quality of life in this group of patients regarding rectum-associated symptoms. And as you see here, for example, with the protons, you are able to spare at least the posterior rectal wall to a large extent. The frontal rectal wall is typically or maybe part of the target volume. And this is one of the reasons why we expect here a significant difference. Still, we are currently doing this kind of randomized trials in order to compare the study and to shed light on the question, is there something beyond the dosimetric advantage comparing the proton treatment compared to the photon treatment, which is shown here? Because probably in this group of patients, secondary malignancies will be not a dominating, but especially because we see now increasing number also of young patients, 60 years and younger. Also, secondary malignancies in this group of patients might be an issue, because we expect currently that we have an aging population, and at least we here see more and more patients over the age of 90 which have been previously treated by radiation therapy. So one of the big questions is, what will radiation oncology look in 2015? So a little bit to look into the crystal ball, what will be the development? Certainly, radiotherapy will remain a key component of the multidisciplinary anti-cancer treatment. And for sure, we are treating here more and more patients in a curative setting, but also nowadays in a setting where we treat oligometastasis. And especially in this group with oligometastasis in combination with immunotherapy and checkpoint inhibitors, it may be a significant approach on the long-term run to use protons in order to spare the immune system. We currently are trying to collect data to prove that hypothesis, that using protons, we get in general better results by sparing immune systems. But this has also been shown currently by a lot of clinical data using the long-term retrospective analysis of proton trials. But protons with higher precision and reduction of non-involved tissue is certainly one of the important points on the long-term run where we have to go for. And this is why I see in 2050 still a growing number of proton centers. The evidence of proton therapy is very high for the dosimetric advantage. So there's basically no clinical study based on dosimetric advantages, which will tell you we have a problem with the protons. There are some challenges regarding moving targets, which I didn't include in my presentation today. But we have growing clinical evidence for the protons. As I show you, for example, with the head and neck trial, we have similar trials for the treatment of esophageal cancer. And there's also increasing data also for breast cancer and also for prostate cancer. Still, we have this continuously growing evidence, which hopefully will give us in the future basically a stronger also argument to use that. If we nowadays invested, this is why I've shown you, we invested now also in the single room particle therapy in addition to our existing facility, because I like this quote of Graham Westy. He was a very famous ice hockey player, and he has been asked by the journalists why he's so successful, and I told them, I skate not where the cook is, but I will skate where the cook will be. And this is also like we have to be. For example, if we nowadays, if we decide on a technology, if we decide on a treatment concept, or if we decide on a study, you have to expect where will the results be when the study will be ready, when I have basically I'm fully operational, and therefore you have to go ahead and go to where the puck is be. And this is currently where we're trying to move, where we've mostly been, where the evidence of efficiency is high, but we'd like to generalize that. We want to be here, that we can also generalize our data to the different other indications. So with that, I've give you a summary of the experience and my view of the proton therapy, where we will move and where we'll go ahead, and I will be happy to answer your questions. Thank you so much. So we can't hear you currently. Dr. Alheim, I can't hear you.
Can you hear me now, Professor?
Yeah, now. Okay,
excellent.
now. Okay.
Excellent. Thank you so much, Professor, for sharing your incredible expertise with us today. That was fascinating. Look at whether proton therapy is necessity or a luxury. To me, I'm biased, and I think it's necessity. And I'm sure our audience has a plenty of questions. So I'll move on with the question. And for the audience, please drop your question in the chat, and we will get started. First question is with Dr. Gandhi. He's asking a pragmatic question. What is the best way to engage stakeholder to help bringing this technology to Middle East, to our region? Any advice on that, Professor?
I mean, you have a lot of expertise by yourself in coming from US centers and also being involved in the proton therapy itself. There is significant interest, and obviously also you have a very young population, so you have a lot of children, and obviously also with children cancers which have to be treated. So from that point of view, it should be very easy to convince also your politicians to invest in proton therapy, because this is meanwhile a kind of a standard of care. So this is more the part how to finance it. But if you have it to get it off the ground, typically meanwhile this is something where you can have a training and also the option that you can now do comparative treatment planning. You can even use without a proton therapy. You can have treatment plannings and learn how to use that. And there is a very strong community which will support you.
Excellent. While we are waiting for the second question, Professor, I think as for us in a field of radiation oncology, once we get excited, like what you mentioned, Stephen Frank randomized trial, the oropharyngeal cancer, that's showing clearly a survival advantage. The Thompson trial, the UK trial, and thank you, you explained clearly the difference between those trials. And Thompson from UK showed that there is no difference, and the IMRT should remain standard. And similarly in prostate, I'm just wondering, Dr. Deepas, how, as a field in radiation oncology, to advertise more or asking more that the proton therapy is the way to go.
I mean, this is why I've shown the data, especially head to head, from how you can differently look at a similar patient set. One is if you look at 2 years, you don't have a difference, because nowadays, especially overall survival, probably also in your group of patients, you see much more patients compared to 10 years ago, which will receive second or even third line chemotherapy, which receive checkpoint inhibitors, cetuximab, or whatsoever for the recurrent situation. And therefore, there will be no difference at 2 years. But on the other hand, it depends also very critically how you deliver the treatment. If you, for example, if you look for esophagitis and you treat always the bilateral neck, so it's extraordinarily difficult to spare mucosa. And therefore, you won't see a difference, because if you include the mucosa in the target volume, it's independent of the treatment method that you will produce some mucositis. And therefore, it's important if you accept that. And the other point is, where is this famous saying? So, no evidence of a difference is not the evidence of equivalence. That means because I've looked at a time point or with a statistical underpower and I don't find a difference, means that there is no difference. This is one of the problem also of the British trial. They looked too early. It needs longer follow-up, and also the way to look at the data is different.
Yeah. Dr. Hoyich asked a futuristic question. Do you think proton therapy will become more affordable and accessible technology in the future more than today?
So there is some possibility, in a sense, that also in proton therapy we go to hypofractionation. So let's say the time of the patient on the machine gets shorter, especially if you do hypofractionated treatments. For example, if you compare the treatment of a liver cancer, typically delivered in 4 or 5 fractions, and I compare that with, let's say, with 20 fractions on a conventional machine, this is a significant difference. And the other aspect is with more facilities up and running, we have also a scaling effect. And when I look to Musha Gu, who's also here in the meeting, about the system of pricing. But on the long-term run, if you have a broader installed base, operations costs are getting lower, and also the production costs.
Yeah, that's a great news, Dr. Shorgu. The IPA will be running in Egypt, Cairo, in September, and hopefully we'll have this technology sometimes in future in Saudi. Next question is Dr. Fahad Ruwais. What are the major obstacles in adoption of proton therapy? Knowledge, evidence, cost, or the practicality? Any efforts in reducing cost of proton therapy technology?
So, as I mentioned, if you look at the aspect of cost, if you do not only look at treatment costs, but also the cost of care, the situation looks differently. For example, at least here, for example, in Germany, it's extraordinarily expensive to have someone on the ward. If one of our kids is on the ward, it's typically more expensive than the proton therapy itself, because it adds a lot of, they need antibiotics, they need some procedures and whatsoever. And if you look for the whole treatment of care, you may be even less expensive compared to the photons. This is one aspect, especially for the treatment in kids or the treatment if you treat large volumes. And also on the long-term run, especially if you look for the care of things like secondary malignancy or consequential of side effects. For example, you have produced cardiac problems or whatsoever. You may have also the additional cost of additional side effects by the photons. At the same time as we speak, we are really interested to see, can we basically also scale down with hypofractionation, are able to deliver more patients with that kind of treatment and save them from approaches like consequential side effects of our treatments.
Thank you. By the way, we just opened the mic for the audience. I saw the hands of Dr. Abdulaziz Al-Ghamdi. Dr. Abdulaziz would like to ask.
Thank you so much, Professor. This was very informative. I myself did my fellowship training at the University of Florida with Daniel Delcato and Bill Mendenhall. So I'm familiar to a lot of your work, and I salute the group at Heidelberg for leading the way and leading the way to get this technology and working. So my comment and question, it's some sort of a comment and question at the same time, is people don't mind paying for precision when it comes to medications that targets a molecule, and they would pay hundreds of thousands of dollars and maybe sometimes $1 million for a treatment. Whereas with Proton, what we are doing is we are delivering a more precise treatment. So if you get a surgery and you do it robotically, you would be paying more than doing it laparoscopically or doing it open procedure. So I think that's the part of the comment. How did you overcome this anxiety of paying more money for precision in Germany? Because I find this is the constraint in Saudi Arabia. People are saying it's expensive, it's expensive. Why are we getting this technology? Thank you.
No, thank you so much. You raised a very important point. So when we look, for example, the cost of a checkpoint inhibitor per year, we are talking about 100,000 euro, and which is about, let's say, 10 times more when conventional radiotherapy and more than 3 times more when proton therapy. And sometimes this is only a very marginal effect, but a significant study. I'm also here the medical director for the whole hospital. I just yesterday signed, let's say, a prescription for a CAR T cell, which is 500,000 euro, and we have some gene therapies for sickle cell anemia, which is currently 2 million euro. So there's currently a highly pricing kind of pharmaceutical approaches coming to us. Interestingly, when we talk about protons, everybody is concerned about the cost of protons, but this will be not the cost driver. It will be even reduce the cost if the total care in the patient compared to what we do. But we have some initial costs. So we have some initial costs which you have to invest, but on the long-term run for society, it pays back.
Dr. Mohammed Al-Hajji.
Yes, thank you, Professor. And I'm very glad of having you here in Saudi to introduce the particle therapy to us. I'm from Gunma University in Japan. I am more like heavy ions, carbon therapy. I did some things there in Heidelberg, which is very interested. And yes, hopefully we will meet again in Bitikog in France if you will visit.
I will be there. Yeah, I will be there.
Oh, beautiful. So hopefully we will meet again. But the question I want to ask you, Professor, is regarding to the result from the United Kingdom and America. I just want to know how the number of patients, because it is very important if you will compare this result with carbon
Right.
Are the number of patients equivalent to be or to claim, are the number of patients treated in both centers are enough to claim that the result is this good? That's my question.
No, as a matter of fact, they treated 440 patients in the US trial and 205 in the UK trial. And this is also regarding, so the US trial is very reasonably also, and the recruiting was also done reasonably well. So in general, this trial gives us a very strong evidence, but the overall survival is also very good because they had, in general, they had, they had 80% P16 positive patients in the US, in the UK trial, and in the US was even a little bit higher. So this is, in general, for prognostically, a very good group of patients. There was only a very small part of smokers in this group, leading to the effect that the response overall was very good.
Thank you, Professor. Thank you for the answer.
Dr. Walid.
Thank you very much, Professor DePose, for your lecture today. Practically speaking, I use proton therapy, or I used to use it like maybe 5-6 years ago. We have a lot of struggles with adaptive planning, especially when you treat bulky tumor. And this comes like a very toxic treatment if you don't do the adaptive, even in the lung, overdose to esophagus, spinal cord, and the head and neck, you goes injury to the temporal lobe and the nasopharynx and the spinal cord and mandibular necrosis for the locally advanced disease. So how frequent do you do your adaptive planning, and how many plans do you do usually in a locally advanced head and neck? Thank you.
Yeah. No, thank you. Very important question, because as I say, if we treat structures which are changing, if you treat brain, this is typically not a major problem. However, as soon as you start treating head and neck cancers, you're faced with two effects. One thing is that the tumor might shrink, which might also lead, for example, if you have large N3 neck and the tumor is shrinking, suddenly for sure your skin gets into a very high dose area, especially if you do something like an integrated boost concept. And the other aspect is if you have a patient who suffers from weight loss or even from swelling of mucosa of the paranasal sinuses, we do that. We currently do in this patient, at least we do every day, we do a positioning, and we try to do as often as necessary a CT. Typically in a head and neck cancer, at least in the beginning, it's done 2 times or 3 times a week, where we do a complete planning CT and do also a new treatment plan, especially in the situation you described, where you have this significant shrinkage and change. And also this is something which is possible for, let's say, for the last 3 or 4 years, because formerly the treatment planning took us considerable time. Nowadays, we can do with this fast planning treatment algorithms, we can do very quick treatment plans and optimization. And you can do, for example, a CT and have a new treatment plan within an hour.
So what triggers your what triggers your adaptive treatment? What is the percentage or CC of tumor shrinkage or weight loss? Because we struggle with this, and I do daily cone beam CT in my practice in the US. I'm at University of Kentucky. So it's just for us, when do we pull the trigger and decide to do this adaptive planning?
Basically, we do a quick planning on the cone beam CT or on our, we have also in a room, we have a full CT. And if we see that on this fast calculation, there's a difference, be it mucositis, swelling, or any kind of weight loss, we trigger this examination. This is also in many instances, we ask the patient on his weight. And if the patient reports that he has lost weight as a rough indicator before the treatment already, we do at least 2 retreatments a week. And with that approach, like we've seen in a conventional radiation therapy, I mean,
well, I feel, to me, sometimes I prefer to treat with IMRT and VMAT for head and neck as a safer protocol to minimize the risk of nasopharynx.
We started with this once a week cone beam CT, and the closer you look, the closer you see there's a difference, and there's no downside if you do it more often rather than to take time. So in the end, you're doing everyday cone beam CT. And I'm pretty sure also in the photon world, the standard of care in 5 years will be that we do adaptive radiation therapy in every patient, and the same will happen for the protons.
True, yes. I mean, I think the Ethos and the Evo platform for variant Electa will make it much easier, but I'm not sure if the proton therapy, they have this kind of on-fly or the on real-time pre-planning. I'm not familiar with that. The old unit that I had, the proton therapy, we used to take KV images, was not equipped with, it was in New Jersey, it was 15, 20 years old, and in Knoxville, Tennessee. So those are like not the very advanced ones. So it was a struggle for us. But thank you very much for your expertise. Thank you, sir.
Thank you, Dr. Walid. Question from Dr. Amani Al-Kufaidi. Dr. Amani, she's a professor and pediatric oncologist. Is there a possibility to make it more affordable, and how much would they cost, and how long does it take to set up? Maybe this is a question for the Dr. Shergo. And Dr. Shergo with us? Or maybe Professor Davis.
Oh, okay.
Assalamu alaikum. Can I also just add a comment?
Sure.
Go ahead.
Thank you so much for a really great talk. And I'm a pediatric oncologist. I mainly do neuro-oncology, but I see other types of cancers. And one of the interesting things is that there was a plan once upon a time to have proton therapy in one of the hospitals here that I'm sure the team knows about, which is King Fahd Medical City. And this was around a decade ago, if I'm not mistaken. But it took them so long to prepare for the proton therapy that eventually, by the time there was enough money to complete it, the things were outdated. And that was over. So we were never able to actually get proton therapy, although there was an attempt to have that in the kingdom. So this is just, that's why I was asking. I mean, if something like this is set up, does it take so long to set up because of logistics or because of money or both?
Okay, so luckily, Dr. Amani, I was part of, I have known this project for 15, 16 years, and also worked with variant proton therapy for 7 years. So the situation with King Fahd Medical City's project is controversial because that was a PPP project where a private investor and in a public setting, and eventually that setting took some years to build. Because that's not we're not talking here as a one proton therapy system with one gantry. That was 4 rooms plus an eye room, so five in total with one cyclotron. Whenever it was finally finished, we were hit by COVID, and then Varian exited the market of particle therapy. So there were a series of problems that hit that project in a way that made it. It's not, I wouldn't say is totally outdated, but it's not state of the art anymore. That being said, your question, how long would it take? Currently, some of the centers that we have signed in 2023, 2024, like we signed 10 systems in Spain, all over the country. Some of them are already in installation, and some of them will start treating this year. So if we can get a building going in 12 months, then we can install in less than that. And so the time between signature of a contract and a first patient should not be more than 2 years at the most with the current standards.
Thank you, Dr. Shergo. It's more complex than what you explained, Dr. Shergo, but I will not go into that detail because of the time. What happened with the Proton facility in Saudi.
Agreed.
Yes. Let's see if do we have any more questions? There's one comment to you, Professor Davis, that the view from your background window, it's beautiful. Radiation therapy is usually located in the basement. Are you in your office, Dr. Davis?
No, I'm in my office. I can see the sky, but this is not this is not this is a virtual background.
Excellent.
But you see the river and the castle.
Excellent. Good. Good.
Dr. Al-Dahaim, there was a comment about the carbon system. So there is a carbon system in Caen. Actually, there are two systems from IBA. There's the Proteus one, so the proton therapy system that will be also installed similarly at Heidelberg. And then there's a carbon system that is being installed. So the people that will be visiting PT Cog, they will be able to see both.
Excellent. That's good. Maybe we'll have one last question, Professor. From Samir Ebai, do you see the field moving toward RBE weighted optimization, or will we stick with a generic 1.1 factor, specifically for adaptive IMPT or boost after photon therapy, or even for re-irradiation?
So in the brain, we see a clear, let's say, or the study, as I've shown you, is still running. But we see that probably it's worthwhile to consider an individualized RBE, which is not generic at 1.1. However, we have to say practically all of the historical data have been generated with this RBE of 1.1, and it works. So obviously you have this advantage that you have a very simple model which is working. However, on the long term front, I'm convinced that that we will run with this individualized RBE, where we have an optimization also regarding the linear energy transfer of the proton beam. And this is something which is now coming. A lot of vendors have that in their, let's say, experimental version. It's not yet a clinical product, but it's a way to go.
Excellent. So, because of the time, Professor, we have an annual conference, the Saudi SARO annual conference every year. This year will happen beginning of October in Jeddah, and we'd love to have you, Professor. We love you visit Saudi Arabia. The exact date will be announced soon,
Okay.
but probably in the mid-October, at sometimes mid-October.
That sounds great.
We'd love to have you. To wrap up, thank you, Professor, for this great insight, and special thanks to our sponsor, IBA, Dr. Shergo, and Magentar, represented by Abdul Jabbar, for their continuous help and dedication to our education activity. Thank you all for attending, and inshallah, we'll see you next time. Thank you so much, Professor.
Yeah, thank you so much.
Thank you. Thank you.
Bye-bye.
Bye.
Bye.
Take care.